So, having said that, I would like to introduce the first speaker of this afternoon session. It's Dr. Adriaan Voors. Do you say Voors? Dr. Voors completed his medical school in Utrecht. He also did his thesis there, working with endothelial function in coronary bypass surgery, which is also an intriguing area with the nitric oxide and all the factors that come into play in the endothelium, which is the biggest endocrine organ within the body. After completing his thesis, he continued over to working as a cardiologist, and he called himself, when you just had a chat quite before I went up here, that he's a heart failure man. I think it's evident if you check him out on the PubMed. He's got many publications in peer-reviewed journals about biomarkers and heart failure in people. He's also a full professor and engaged in many different organizations that are engaged in heart failure therapy and heart failure studies.
So thank you for this introduction, and also many thanks for the invitation here to speak about this very interesting subject. This is my hospital. I'm working in the north of the Netherlands, and even people from the Netherlands often have never been there in their lives. It's a pity, because it's a very nice city and a very nice hospital. It's actually the largest hospital in our country, and we have quite a big reference area there, so that's why. So this is Groningen. What I'm going to talk with you about today is about the clinical application of biomarkers. And it's a very interesting topic, because you can go many ways. I go with you 5 ways I will introduce to you. And also I'm going to limit myself a little bit to talk about biomarkers in heart failure, because I'm indeed a heart failure cardiologist, and I have most experience in heart failure. The second reason is that I believe that the field of biomarkers have emerged tremendously in heart failure over the last years. This is a paper recently published by Eugene Braunwald. He's a godfather of cardiology. He's a very important person there, and he had a nice paper, and it was under the topic of medical progress. So actually that's what I'm going to do with you, like to evaluate with you what can biomarkers help us with treating the patients or the animals. So that's my topic of today. Like I said, it's booming. The biomarkers are booming. As you can see that in 1998 there were only a few publications about biomarkers, and this is only about heart failure, biomarkers in heart failure. I mean, the other is going off the sheet. So this is only in heart failure, and you can see the tremendous increase in publications about heart failure. And this is all about the interesting aspects of it, but also novel techniques in detecting novel peptides that can serve actually as biomarkers. So that's why this is booming business, so to speak. We have quite a couple of biomarkers now at present. This is only a selection. This is from this paper by Eugene Braunwald. And you can categorize actually the biomarkers. You have like inflammatory biomarkers or oxidative stress biomarkers, extracellular remodeling biomarkers. So there are actually biomarkers that tell us something, what is going on in that patient or in that animal. And that's what makes them interesting. So I will only touch upon a few of those markers in this presentation, because every one of them is a lecture by itself. So I'm only going to focus what can we use them for? What can we use them for in clinical practice when we practice medicine today? And what I'm going to do actually is to focus on 5 potential applications. There are probably more, and you will be able to come up with more. This is, I think, the 5 most interesting and important ones. The first one is actually a very interesting one and a very good one, is the diagnosis of the disease. The second one is, and it's a little bit of a sidestep I'm going to take, because I'm interested in the cardiorenal syndrome. I know after the break there's going to be a lot more about cardiorenal syndrome, but since it's my topic, I'd like to touch upon it as well. The third one is, I think, to be critical, not the most interesting one, but still the one that takes up the majority of the papers that have been published so far, and that's prognosis of the patient. The fourth one is that we can use the biomarker for a biomarker-guided therapy or follow-up. And the fifth one is that and that's I think a very promising one for the future, is that we can actually use the biomarker for our choice of therapy. That a certain biomarker elevation can indicate that this is an animal or a patient that is in need for a certain type of drug. I will give you one example of that. So to start with the first one, this is diagnosed, and I immediately go to the most important marker that we have in heart failure world today, and that's the natriuretic peptides. And as you can see from this figure here, that it is actually, the first one was BNP, and that was actually called brain natriuretic peptide. It's a bit confusing because we use it as a cardiac marker, but it was called brain natriuretic peptide because it was first detected in the brain, but there's a much more produced in the heart. What happens is if the heart gets stretched or whether there's pressure on the heart, then the heart starts to produce BNP, which gets into the circulation. And also its inactive N-terminal part, so-called NT-proBNP. So when we find this in the blood, it's actually a sign of stretch or pressure of the heart. And it's also got a physiological function because it actually increases naturases and it gives vasodilatation. So we are also testing now the effects of giving human recombinant types of BNP in the humans, but so far we have not been very successful to treat patients, for example, with acute heart failure. But anyway, these are very interesting markers for indicating that there's something wrong with the heart of the patient. This is a landmark paper of Alan Mizell, and it's a very simple approach. What he and his group did, they looked at patients that were admitted at the emergency department with acute heart failure. So when I was in the car yesterday, I heard about dogs presenting also often with heart failure or with signs of breathlessness. So you need to know, is this a pulmonary problem? Is this a heart problem? That's the major question we need to address. And so what he did, actually, he retrospectively looked at the biomarker. So the patients were in the emergency department, and there were all kinds of doctors running around doing all kinds of tests and things. And at the end, they made the diagnosis: was this really heart failure or was this pulmonary disease? And then afterwards, he looked at what the levels were of the biomarkers in those groups of patients. So there are actually 3 groups of patients. If you can look at the blue group, I don't think, it's visible, but you can see that the ones with the blue ones are actually the patients without heart failure. You can see that the BNP levels are very low. Then there is a group of patients who do have heart failure, but the primary reason for their dyspnea was at that moment not the heart failure. So that's a sort of an intermediate group. And then you see the high group, the red bars. You can see that this is the group that do have heart failure. So you can really see there's is much higher than those who don't have heart failure. And that's very interesting. And you can also look at it a different way, making this receiver operating characteristics curves. They actually give you an indication how good the marker is to predict something. And in this situation, to predict whether the disease is present or not. And this is an AUC, an area under the curve of 91%, 0.91, which is incredibly good. There's hardly any mark. So if you are above 0.8, then it's good. Between 0.7 and 0.8, it's reasonably good. And below 0.7, it's not very worthwhile. But if you have 0.5, it's just flipping a coin, so to speak. So the higher the curve goes up in the corner, like that, you can see the better the predictive value. So 0.9 is really fantastic. So now we have a marker that is really good at predicting in an acute setting when patients are dyspneic at the emergency department whether the cause is primarily the lungs or the heart. I think this is very worthwhile, and that's therefore we use it a lot for this particular diagnosis. It's in the guidelines that we should use it in the diagnosis of heart failure. Now the question is, can we do any better? Because 0.90 is reasonably good. Well, there have been attempts, like for example a mid-regional pro-ANP marker that should be more stable in the blood. You can see this in the middle here. And actually it's performing similar to the BNP and the NT-proBNP. And I personally think this is 0.90, I think you shouldn't try to get any better because it's hardly impossible to get better. But maybe there is still some room for improvement. You will never have a marker that predicts 100%, of course, because then, you can just let a computer decide whether this patient or this animal does not have heart failure. So, what are the unmet needs at the moment? Well, we are doing pretty good with the BNP, but we should have as high as we can a negative and a positive predictive value. At the moment, this BNP level that we can see is mainly used as a sort of a rule-out test. So if it's below a certain threshold, we can rule out that there's BNP. On the other hand, it's a little bit less specific, which means that if it's elevated, it can still be caused by other diseases. For example, pulmonary embolism gives stretch of the right heart and can give elevation of BNP as well. So there are many other reasons. So there is some room for improvement in the positive predictive value. And there can be room if it is really specific for the disease. And BNP is reasonably good, but it is also influenced by kidney function, for example, which is one minor flaw. It should be cheap, because as I said, you will always need other examinations, other things to make the final diagnosis. Well, BNP is not very cheap, so to speak. I think a sodium, for example, is much cheaper, but doesn't do the job as well as BNP. And it should be, finally, easy to measure. You should have it available immediately when you're there with your dog or when you're there at the emergency department with your patient. You should have your marker reasonably quickly, because those are animals or patients that are in need of treatment, and you need to find the proper treatment. So, diagnosis, I think the biomarkers can be very useful. As I promised you, I'm going to make a little sidestep. That's a cardiorenal sidestep, because markers can do more than just do the diagnosis. They can tell us something about, for example, hemodynamic status of the heart. And this is particularly interesting if we look at renal function. And cardiologists tend to become more and more interested in renal function. Why? Because renal function is actually a very sensitive organ for changes in volume status and changes in cardiac output, as I will show you in a minute. We tend to use renal function a lot already during the last more than a decade now, more and more, because it's one of the best prognostic markers. And it can really predict whether a patient is going to die or not. This is one example. There are, I think, hundreds of examples of papers in the literature that you can see that if you use quartiles of GFR, glomerular filtration rate, which is renal function, this is by definition. So the ones with the worst renal function, that's the upper curve as you can see in the figure, they have the highest risk of death in the left panel, or the combined cardiovascular events in the right panel. And by quartile, it's getting better and better. So it's a very good predictor. Now, this is not the only thing. And it's, as I told you just recently, it's just also can tell us something about the hemodynamics of the patient. And that has all to do with the autoregulation of the kidney. The kidney is a very intelligent organ, and the kidney must maintain his urinary output despite changes and fluctuations in hemodynamics. For example, if we get a blood pressure drop, the kidney must still be able to have enough glomerular filtration pressure to excrete enough urine and excrete enough proteins and other things that should get rid out of the blood. So what the kidney can do, it can maintain, as you can see, its glomerular filtration rate, which is on the y-axis, up to a huge amount of changes in blood pressure. This is in the normal kidney. However, in the heart failure patients, we very often see kidney dysfunction. And if we see kidney dysfunction and hypertension, you can see that the amount of change in blood pressure that the kidney still can handle gets much less and less and less, as reflected here by the solid line. So that is the problem in heart failure, that the kidney cannot maintain its intraglomerular pressures anymore, and then it becomes a very sensitive marker for changes in hemodynamics. And how is the kidney doing this? So basically what the kidney needs to do is maintain its intraglomerular pressure. It has to maintain this in order to have enough urine output. So it can do it by both ways. First, it can regulate how much gets into the kidney. And it can do this by regulating the diameter of its afferent arteriole. So it can regulate this. So the wider it gets, the more blood gets into the kidney, the higher the intraglomerular pressure gets, the larger the urinary output. On the other hand, it has a second mechanism, that's the efferent arteriole. It can also shut down its efferent arteriole, and by doing that, it will increase its intraglomerular pressure as well, maintaining his GFR. So that is actually how the kidney is doing this. Now, what's happening in heart failure? And this is, I think, one of the most important remarks here from this particular indication. That is, when the cardiac index is reduced by 25%, then the renal blood flow goes down by 40%. So we say that maybe the kidney is a sort of a self-sacrificing organ. So, hey, you're in trouble, your heart, you're in trouble, I help you, just shut me down and give all the blood you have to the brains or whatever other organs are necessary. So that's what the kidney is doing. And then the kidney says, I can handle myself, and the kidney is actually then have his afferent arteriole contracting, increasing its filtration fraction, maintaining its GFR, despite a reduction in the renal blood flow. So that's actually a trick of the kidney. So the kidney can maintain this by doing that. But this is very important. Those were patients at an earlier stage who were not treated by an ACE inhibitor. And you're all experts in this field, I heard. So what we do with an ACE inhibitor, one of the major functions in the kidney is that it gives efferent vasodilation. So in fact, what we do, we take away this protective mechanism of the kidney, not allowing this dog or this patient anymore to maintain its GFR. So this is what's happening if we do it with the ACE inhibitor. You can see an immediate drop of the GFR if you go from left to right. If your renal blood flow drops, you get an immediate drop in GFR, and that is what's happening in kidney function. So therefore, actually, an increase in creatinine or a drop in GFR is a sign or indication, a very sensitive sign, that the cardiac output is going down. Not only that, if we look at what's happening, what's determining GFR in heart failure patients, then you can actually see those are two things, and those are here in the middle. This is the renal blood flow, like I just explained, but there's another aspect. And this other aspect is the central venous pressure. So if patients or animals have heart failure, you don't not only get decreased cardiac output, but you get also an increased congestion. And therefore, this is difficult for the kidney because then the blood has more difficulty to get out of the kidney. So it's a sort of a sandwich construction. So both of them makes the kidney vulnerable. And that's interesting because that we can use and play with these markers. And this is the same actually for liver function tests, that some liver function tests can indicate there's congestion and some can indicate there's a decreased cardiac output. And therefore, to put it in a graph, if we look at this patient again with acute heart failure, we have done the BNP, we know it has heart failure, we give him diuretics and nitrates, and we can do two things actually. We drop the blood pressure, which is not good for the kidney. Kidney gets sad, it's a drop in blood pressure. But on the other hand, in some patients, especially the congested patient, we decrease congestion, and by that we might improve renal function. So we can play, and that is actually, this is one example, but the liver function tests are other examples. We can play with the biomarkers to see what's happening within the patient and adjust our treatment according to that. So that was just a side step, and now we go back to what the majority of biomarkers are used for, and the one I'm most critical about, and that's prognosis of the patients. I'm a co-editor of the European Journal of Heart Failure, and every week we're receiving a huge amount of papers with, again, novel markers to predict prognosis in heart failure patients. And they're good at that. They're very good at that. This was one of the first ones. This was norepinephrine, 1982. And you can very simply see that those patients with the lower levels, below 900, actually had a better survival than patients with the higher levels. Very simple. Now, this has taken enormous steps, and there have been many other markers. Again, the BNP has been a very good marker. And if we look at this graph, this was from Valhev, more recent, 2004, and they looked at several neurohormones or biomarkers, and these are heart failure patients. And what you can see that the hazard ratio for mortality and for the combined endpoint is actually much larger with a BNP than with norepinephrine or plasma renin activity or aldosterone. So actually BNP is again a very good prognostic marker here. And so we use it, we might use it for that. This is a study we did in the general population, the biggest one so far. Those are patients in the region of Groningen. I just showed you the hospital. And patients, they all sent in, we all had labs from the patients and followed them up for at least 7.5 years. So there were more than 8,000 patients, 50% males, 50% females, and the mean age of 50 years. They were healthy. They only had a slightly little bit of albumin in the urine, and that's why they were selected. But in general, they were healthy patients. And so we followed them up and we looked at all-cause mortality and at cardiovascular events. And what you can see here, if we again look at quintiles, you can see in those patients who have not even very high levels, but 87.5 in the upper quintile, you can see that their risk for death and for cardiovascular events is already very much increased. So even in the general population, we can actually demonstrate that there's probably something of a pre-state of the disease present that makes them die at an earlier stage than those who have low levels of BNP. There are other prognostic markers. In fact, there are hundreds of them at the moment. But this is one other very interesting one. This is adrenaline. Well, it tells you where it comes from. It's also increased in patients with heart failure. It's very similar because it also had multiple protective effects, just like BNP. I will not go into depth what it's all doing, this adrenaline. But there's a company that actually, because this is very unstable in the blood, but it made a very stable compound, the mid-regional pro-adrenaline, and looked at the prognostic value compared with the BNP, because BNP and anti-proBNP are the golden standard at the moment. So they looked at whether this mid-regional pro-adrenaline was actually stronger than BNP and anti-proBNP. A big study, 1,600 patients, of which in the end 568 had acute heart failure, 74 years for a heart failure population that's young, 90 days follow-up, and they looked at mortality. And this is again this receiver operating curve characteristics. And now you can see another type of curve. You can see that the area under the curve is 0.67. Not too good. This is only very marginal. So you miss a lot of patients. So that means that a lot of patients without elevated levels of mid-regional pro-adrenaline still dying, and the other way around as well. So it's reasonably good at predicting. Actually, in fact, it was as good as BNP and anti-proBNP, and it had additive value if you gave it on top of, if you measured it on top of BNP and anti-proBNP, but not the other way around. So there's some indication that it's reasonably good, but personally I think 0.67, room for improvement. So the room for improvement might lie in the fact that we use multiple biomarkers. Because as I showed you in one of the first slides from Eugene Braunwald, we have clusters of biomarkers. So we might, for example, use an inflammatory marker, we might use a cardiac damage marker, a neurohormonal marker, and that's actually what the people from this Swedish study did, and they tried to see whether this addition of multiple markers improved actually the prediction of death. And so their aims was to investigate whether this combination of biomarkers, for example, one that reflects myocardial damage, one that reflects left ventricular dysfunction, one that reflects renal failure, whether it improved risk stratification on top of the clinical marks. I mean, if we look at a patient, has an increased heart rate, for example, is dyspneic, has Newark Heart Association, class 3 or 4, whatever, there are already indicators that this patient is going to do poor. So what is the additive value of these biomarkers? And as you can see in the table, I hope you can see it a little bit, but I can tell you, and you will get the slides later on, that adding these markers actually improve the predictive value, and you end up with an area under the curve of a little bit less than 0.8. So it's getting better now. But still, I think we have to be very critical about these prognostic markers. There are many prognostic markers in heart failure, and the question that we really should raise here, what is the added value of them? Maybe even multiple markers are better, or multi-marker strategy is better. And there might be specific situation or indications which we can use in making a risk engine, for example. But the major problem here is, who cares? Of course we care about the prognosis of the patient, but what is it going to help us in clinical decision making? Are we going to use it? Are we going to change our treatment? So as long as there's no evidence that measuring this marker actually going to change our clinical practice, I think it's useless. So therefore I'm very critical about all these prognostic markers that we have, and the next step that we should do is actually take these markers into trials and to test them, whether if we use these markers, they will actually improve my and your clinical practice and improve outcome of our animals and patients. And that is what is, I think, important. So one attempt, fortunately, was made by this anti-pro-BNP and BNP. I think it's a very good attempt. So what they actually did, there was multiple tests or multiple studies to test whether if you take this marker and you sample all the time that the patient or the dog gets back into your clinic, and those animals or patients with elevated levels, we treat them more aggressive. And if we have low levels, we just take a lenient approach. We say, okay, we don't need to up-titrate the therapy, we don't need to be that aggressive anymore. And this was actually tested first in the landmark paper of Troughton, published in Lancet, actually a very small study, but very interesting. So he randomized the patients into two groups. In a group that was that the treatment was based on the BNP levels, and the other group in which the treatment was based like just do what you always do. And he actually showed in this small group that if you look at the survival curves, that those were all heart failure patients, they were all well treated, but if you even increase the treatment according to this BNP level, you did better. And that was really something. This was a pilot study, so then it was repeated in the bigger studies, and as we see very often, then it gets more difficult. This is a very interesting one of the examples. I'm not going to show all of them, but this is a bigger one, 364 patients, the battle scarred. And the interesting part about this study was that we had three groups. So one group was care as usual, just do as you always do. The second one, take a clinical score and look at symptoms of patient, look at heart rate or whatever other things were present. And based on this clinical score, then treat aggressive, more aggressive or less aggressive. And the third one was do the same, but then only with the marker, with the BNP. So this was three groups, and what you can see here is that the primary outcome, that there was no difference between the one that you just used a clinical score, which we have always available, we don't need the biomarker, was just as good if we used a biomarker for follow-up. It was better than care as usual. Why? Because in the two intervention groups, the treatment was more aggressive. And this is actually the biggest one, 500 patients, chronic heart failure patients, the time CHF, also heart failure patients, ejection fraction less than 45%, and these had only the two groups. So a symptom-guided care group or a BNP-guided group. Again, similar type of patient, they used different thresholds for old, elderly and younger patients. The primary endpoint was an 18-month survival-free of any hospitalization and quality of life at 18 months. And this study didn't show any difference between the groups. There was a subgroup analysis showing that if you only take the younger patients below 75, there might be an effect, and the elderly patients might not be an effect. But in the end, overall, there was no effect. And this was even more strange if we take into consideration that those patients were actually more aggressively treated with the ACE inhibitor or the angiotensin receptor blocker, more aggressively with the beta blocker. So we expect this should have led to a better outcome of the patient, but it didn't. So unfortunately, the BNP-guided therapy, so we do not advise at the moment to routinely take the BNP all the time and use it for how aggressive our treatment will be. So if we look at how can we improve this, because that might be an interesting approach with the biomarkers, we should find a disease-specific biomarker. I think BNP will do reasonably well. But then the big problem is the variation. So the biological variation versus the pathophysiological variation. What I mean with this is that if a patient is fully stable And he comes in your clinic at one moment, then his BNP can be 600, and at the next time it can be 1200. Because this is the biological variation of the marker. So as long as this is just around as big as the changes, then you have a real problem. I think that might be one of the major problems at the moment of BNP. So there is room to improve, but I have to congratulate everybody with doing these studies, because everybody can come up with predictive value. It's very easy to do, but this is difficult to do. But we should not let our clinics be overwhelmed with all those markers if we're not going to use them to change our clinical practice. So then my final slides, and maybe the most interesting potential application of biomarkers. And that is that we can use the biomarker, we maybe use the biomarker for guiding which type of treatment are we going to use. So maybe if we have a panel of biomarkers, a multi-marker strategy, and we look at, hey, look at the panel, we see inflammatory markers increased, and we can maybe use an anti-inflammatory agent. And if, for example, neurohormonal markers, then we must aim it directly at the heart. Or is the kidney function might be the major problem, the primarily problem, we can target kidney function. So actually that, I think, I get most excited if I hear about that type of application. But I didn't see too many as yet about those studies. But again, they should be done. There's one example, actually. There are more examples, but the interesting example that's very obvious. This is a design that patients with hypertension were randomized to various therapies. To placebo, to hydrochlorothiazide, to the beta blocker atenolol, to diltiazem, the calcium channel blocker, and to the ACE inhibitor captopril. And the endpoint was, they treated them for 6 weeks, and the endpoint was how many patients responded, which means that they had a diastolic blood pressure below 90 millimeters of mercury. So what you actually see is the following. This is a little bit complicated, but it's also my last slide, my before last slide, so I briefly walk you through it. You see tertiles in the green, blue, and gray bars. And the green bar is those patients who had low renin levels. And the blue bars are in the medium ones, and the gray bars are the ones with high renin levels. And what you can see is very interesting. First of all, that hydrochlorothiazide doesn't seem to have an effect. So the responder rate is less than 10% in patients with high renin levels. But in contrast, if we look at the other side, at the captopril, you can see there's almost 100% response of the ACE inhibitor in those with high renin levels. So if we treat patients, in general practice we don't do this, but we should do this more often, to first take your biomarker and take your first approach with your antihypertensive therapy. And I think this is going to be done much more often in the future, and it's a very interesting application of the biomarkers. So in conclusion, I walk you through some potential implications or applications of biomarkers. First, it can be used at early detection, maybe of subclinical disease, like I pointed out with this PREVENT study in the general population. The BNP might be already an indicator in an early stage that there's something wrong. Secondly, it can make the diagnosis of the acute or chronic syndrome. I showed you in the emergency ward how well BNP does in discriminating between the patients with and without heart failure and with or without pulmonary disease. It's very good at risk stratification. I've shown you that there's very strong markers, but I don't care too much about risk stratification if we don't do anything with it. And I think it might be very interesting to monitor the disease, to progression or response to therapy. And for example, I referred to this renal function test that you can actually monitor the patient how he is doing or is doing not. If you get a sudden increase in creatinine and in your transaminases of your liver function test, that might be a strong indicator that cardiac output is suddenly going down, for example. And most of all, I think selection of therapy might be a really very interesting, novel application of biomarkers in the future. Thank you very much.